hotel booking. You may be just chatting with a computer, following your speech, and you are asked maybe very simply to reply yes or no. Then what are the types of AI? We got reactive machines, and these are the most basic type of AI, which can only react to current scenarios without any memory of past events. So these are reactive machines, something really happening at the time and at the place. Limited memory machines. These can use past experiences to inform future decisions, such as self-driving cars. But as we all are very much aware, self-driving cars or buses have been so far only a great promise, which have to show that they really work. And this is not yet the case. This is not even surprising. Theory of mind machines. This would understand emotions and social interactions, but this type of AI is still theoretical. This might be also a little bit scary. Then one concept listed, which is still theoretical, is self-aware machines. The most advanced form, which would have consciousness and self-awareness. This may be also something you should be very much concerned rather than happily welcoming. Now you find, among others, this nice paper. It was authored by my last PhD student in Hong Kong, Dr. Ding Hao. You'll find it very easily, and I recommend you as some reading to consolidate your basic knowledge of AI. It's always very good to take a quick look at history. Without history, we can't understand the present day or even tomorrow. During the war years, artificial neurons were invented in 1950s. Dr. Turing's imitation game was reality, and he's, by the way, from Manchester. We have even a university building named after him. 1955, Dartmouth Conference was organized in England to discuss the current or that day development. 1965, ELIZA, Natural Language Processing Computer Program, was introduced. And in early 1970s, what we call as the first AI winter. What means AI winter? You guys don't have to worry about winter in that latitude. Maybe luckily, however, if you are into winter sports or interested in, then you have to head up somewhere up to north. Winter in this case is referring to a miserable time when no funding, no really understanding, no patience was available for artificial intelligence. I mean, there were no real development steps and no outcomes. So the question was, what's the use? What's the point of spending funding for so-called artificial intelligence? In 1980s, rule-based expert systems were introduced in computers. In 1990s, something like 30 years ago, we had a second AI winter, and the issues were again, is this worth spending taxpayers' money when we don't have any real outcomes? 1997, we have an example. where chess champion Garry Kasparov was bet by Deep Blue chess player, which happened to be based on a computer. 2009, we all remember those first news. That I remember that was my second year in Hong Kong, and you could read that, hey, autonomous cars are available. But now, when you think we are living 2026, it's like 17 years ago. Do we see self-driving cars around us? In the 1910s, personal assistants, for example, Siri, Google Assistant, Cortana, and many more were introduced. And less than 10 years ago, AlphaGo was defeating world's best Go player, Imkg. Then let me take this picture here introducing what we are talking about. We can see something very much massive change. So if we have a first industrial revolution, which was based on mechanical loom system, you can see the time scale on the bottom. Then we have second industrial revolution through the introduction of division of labor and mass production with the help of electricity. And first mechanical revolution was based on water and steam power. Then the third revolution, not so long time ago, was based on the use of electronics and information technology systems promoting automated production. And now we can call this as the fourth industrial revolution through the use of cyber-physical systems. What are cyber-physical systems? They are artificial intelligence. So the term artificial intelligence was created already in the 1950s without people even knowing what it would be in the future. It's about building machines and devices capable of performing tasks that are normally performed by humans. Machine learning is the subfield of artificial intelligence. Certain algorithms are developed and applied to learn the intrinsic statistical patterns and structures in data. And AI is a prediction tool of unseen data. I mentioned the expert system. This is very important to understand what's the difference between expert systems and machine learning. So in the olden days, there was always a knowledge base based on inputs from experts. And there was an interference engine called computer, whatever is physically inside a computer, and user interface. And when you were posing a query, you get an answer as an advice. So this was requiring a knowledge base. But in artificial intelligence, we are talking about an input layer, then we have so-called hidden layers, and then we have an output layer. So the structure is very much similar, but this is only formally the similarity.
Dokter Ali itu saya.
And here we can see that we have several inputs. And in this case, this is about designing premolars and molars, as I'm going to show a little bit later during this presentation. Input layer 1, 2, 3, and to N, then hidden layers H1, H2, and so on forth until Hn, and then outputs are the real products. So when we, and this cartoon is also, I believe, very much interesting. It's explaining natural intelligence, expert systems, and artificial intelligence. So natural intelligence is about perception and biological response. So interpretation leading to response. And then computer intelligence, it does not replace human responses, but may largely support human interpretation and action. And in expert system, we have data and rules, explicit programming leading to interpretation and actions of human agents. Whereas in artificial intelligence, we have machine learning, data and outcomes, engineered features, feature mapping leading to the same interpretation and actions of human agents. If we have so-called deep learning systems, that is taking us to data and outcomes, feature learning and mapping, and then interpretation. So here you can compare how the simplified structure looks very much similar, but then what is inside the processing part is significantly different. So we are now talking about building machines and devices capable of performing tasks that are normally performed by humans. Certain algorithms are developed and applied to learn the intrinsic statistical patterns and structures in data, because this may be something we don't necessarily see very easily, or it would take months, if not years, to understand what we see in the data. Artificial intelligence is a prediction tool of unseen data. So this is important to make the distinction. Artificial intelligence, it doesn't know really too much. If you use ChatGPT for asking or making summaries for yourself, you should treat the outcomes with great caution and with great care, because they may be also non-reliable. In the healthcare sector, AI is still stirring both concerns and hopes. Among the concerns, there may be several. Let me mention fear of job threats, challenges in distinguishing between truth and falsehood, and the ability to objectify model interferences. And there are also risks to personal information integrity and individual freedom. Moreover, on the other side, namely on the side of hope, despite the current abundance of rhetorical caution, this is what I seem to be doing throughout my whole presentation, and that's my duty as a teacher, there are potential benefits. What are these benefits? It could be increasing productivity, enhancing safety, and saving your time. For healthcare providers, it might also include less administrative duties and more direct patient care. The first thing to mention in medicine and AI is apparently diagnostic imaging, because diagnostic imaging is very central in many healthcare fields. AI is suitable to overcome the variability in subjective individual examination. Digital health data, they are still today very much ubiquitously collected, but a major problem is that they are rather heterogeneous. Heterogenic material, which need curation and structuring. And curation doesn't need that we are changing the data. It just may mean handpick data and type it just in a slightly different presentation form, using a comma instead of dot, or omitting zeros from the beginning of a number or anything. The third benefit in in medicine is AI allows to integrate different data domains, at least in principle. And what would it mean? It would mean combining medical and dental history, socio-demographic and clinical data, imagery data. You can just imagine how many different type of X-ray photos there could be available, either physical X-ray images or digital, biomolecular data, even social network data, strongly referring to the present days. As the fourth main point, AI is facilitating research and discovery. And this would be something very much attractive for all of us who are into research and discovery. In silico experimentation options, and in silico means literally doing things in silicon, in other words, with computer. And that could include complete other research levels and existing modeling strategies. As the fifth point, AI streamlines routine work, at least ideally. What would it mean? We could have maybe more face-to-face time for doctors and dentists and their patients, more humanized care. Everyone would love to meet the dentist face-to-face or the doctor instead of communicating by phone, given 5 minutes time for a phone call or a chatbot. And diagnostic assistant systems could be available. And this is getting very much interesting. AI could make healthcare more participatory. Patients could provide their data actively. And there are a number of wearable monitoring devices already available for example, blood pressure, diabetes, and many more. It could be about self-monitoring and self-management. But then here the drawback is apparently that the patients also should be trained. And if we have someone from the aging population, are they comfortable with wearable monitoring devices or not? And do they remember to follow up the self-monitoring schedules? Number 7, using continuously collected data. So this could mean we wouldn't have anymore the so-called on-off medicine. Not anymore seen only for a few minutes. Non-invasive monitoring of health and behavior would provide a deeper individual understanding of the drivers and processes underlying health and disease. So this would apparently lessen the burden for the healthcare providers. Yet number 8, diagnostic and treatment costs. We have to be very much cost aware in healthcare and providing, say, dental services. Could these costs be decreased? Possibly. Also, relief of healthcare systems that are now burdened by an aging society, in particular in many Western countries, like the United Kingdom. AI might also address shortages in workforce. The problem may be that we don't have enough healthcare providers right there where the patients are, in some remote areas of a country, for example. the development costs of a chatbot equipped with medical expertise may seem prohibitive financially and in terms of resource and carbon footprint. Nowadays, we should always pay attention to ecologically sound solutions and lessen the carbon footprint so that we would produce as little as possible more carbon dioxide. However, their occasional use by individuals incurs minimal costs. So chatbots in service of healthcare are worth for a thought. The question of whether this will include the use of sensors interfaced with or embedded in mobile phones is unclear in the short term. Could a single mobile app be a key to our troubles? Nowadays, there are many applications you can just with a touch of your finger measure your blood pressure and get an idea, at least very quickly, of your health status. How reliable it is may need more development. And during our days, access to medical expertise is about to become universal. So if you only got wireless internet and the devices, then you would have the access. So in dentistry, I have divided this to 8 sections. This is what we are now most craving to learn. So diagnostic imaging and early detection. So AI-powered algorithms, they may analyze dental X-rays, images, CBCT scans, and any intraoral photos with high accuracy. These are the 3 major things today. And these algorithms analyze also the key issues in dentistry we are interested in. They may analyze dental caries. They may spot periodontal disease. The algorithms may draw your attention that there are some unclear changes visible during a certain period in the pictures taken on the patient. And oral cancer is one of the most serious concerns in many countries for different reasons. Periapical lesions, following up bone loss. So the algorithm might draw the doctor's attention that now the bone loss seems to be speeding up. And then something may be terribly wrong. In case of implant dentistry, peri-implantitis, following what's happening between the abutment and in particular the neck area of a dental implant. Is bone loss taking place also there? Do we see changes at the tip of the dental implant showing signs of peri-implantitis? And many other anatomical landmarks we can only imagine. And these algorithms could enable early intervention, improving prognosis and reducing, hopefully, invasive treatments. But again, it's about having an algorithm, but does it substitute a clinical eye? Not necessary. So if things go more personalized, so AI synthesizes patient history, genetic lifestyle, and imaging data to create individualized, data-driven treatment plans. Very much ideal. For example, orthodontic applications could include prediction of tooth movement and custom aligner design. In implant dentistry, the benefits would include guided implant positioning, suggestion how the implant could be positioned, bone density evaluation. This is very much important. Do we have the contraindications for dental implants anyway at hands? And surgical assistance with robotic systems, possibly. But then what's the benefit of having a surgical robotic systems versus a trained clinical hand? That's another question. Predictive analytics forecast disease progression and treatment outcomes, enabling preventive care, possibly improving preventive care at home. Something about automation and workflow and how they could be optimized. So AI is automating routine administrative tasks, which could be appointment scheduling, billing, even insurance claims, if there is an insurance coverage, documentation, including voice-to-text clinical notes. And this is certainly one part where one could be saving everybody's times and nerves instead of having someone typing what someone is speaking on a recorded note. It has been said that AI is reducing time spent on documentation by up to 30-40%, freeing clinicians to focus on patient care. Moreover, AI is also streamlining practice operations, enhancing efficiency, lowering costs, benefiting both large dental service organizations and smaller independent practices. These are certainly four aspects to pay much attention to. Then when we think about use of AI in production flow, and this might be very exciting from the point of view how with dental materials we could have a benefit. So AI could be used by and large optimization of production scheduling. When would we need this much production rate? When is the market demand very high? And when is the market demand low? One example, if we have some milling and drilling systems, as we do have also in dentistry, automated metal chip detection and removal from the machining and cutting tools. As we already have made reference, natural language processing for machine maintenance. This would be including machine condition monitoring fault diagnosis. Otherwise, those are things that someone should keep a keen eye on. Is the production working well? Also, human activity recognition for assembly, for the workers to achieve high level of assembly quality. I'm presenting two examples of dental materials and AI applications based on our recent work. This was about morphology and mechanical performance of dental crown designed by 3D DCGAN. Some of you may be already familiar. In this laboratory study, we were utilizing an AI method, 3D convolutional generative adversarial network, and this is the abbreviation for 3D DCGAN, which is still today one of the true 3D machine learning methods to design, for example, a dental crown. And in this setup, we had 600 sets of digital casts containing both mandibular, second premolars, and the adjacent and antagonist teeth from healthy personnel using 3D DCGAN. Moreover, 12 sets of data were used as the test dataset, whereas the natural second and premolars in the test dataset were compared with the designs, and then we have 3D DCGAN, CEREC, biogeneric, and CAD for morphological parameters of 3D similarity, cusp angle, occlusal contact point number and area, and then computer fatigue simulations using finite element. And as the crown material, we decided to go for lithium disilicate. Let's see, just a couple of pictures to give you an idea what is it about. So on the left-hand side, you see a schematics showing the finite element model. And as you can easily see in finite element analysis, we are creating these tiny wee elements and seeing how they are behaving. You see the testing position of the whole model, and then on the right-hand side, intender. So we were applying like metallic intender on the crown, then ceramic crown, adhesive layer, and dentin. And this is very much how the dental crown is even cemented. And just as an example, on the right-hand side, you see a picture showing life estimation as a function of force. So four different groups here as logarithms of cycles. A is referring to central fossa. Sorry, that picture I didn't attach here. And this is the contact point area now, referring to the left-hand side picture. Then if you first take a look at the right-hand side, you may see something about the setup, a vertical cross-section view of premolar indicating the cusp angle and cusp plane. Very much important. And on the lower picture, one set of training data, 4, 4, 4, 5, 4, 6 teeth, and so on forth. And what did we then conclude? So we were thinking that a new artificial intelligence approach to design dental crowns based on a true 3D deep learning algorithm showed that the least discrepancy with natural teeth compared to a couple of groups. And regarding occlusal contact points and area, they all three have a comparable occlusal relationship that match very well with natural teeth. Then regarding the fatigue properties of the lithium disilicate crowns, dynamic finite element analysis revealed no stress concentrations for our AI-designed crowns. And that was the exciting finding. And the estimated lifetime was best matched with natural teeth. So here, one idea, for example, if you are interested in going for an application. Then I want to show another example. Also, it's very recently. A simple AI-enabled method for quantifying bacterial adhesion on a set of dental materials. And aren't we interested in pellicle and biofilms and biofilm persistence on the surfaces of restorations? We certainly are. And the purpose here was measuring bacterial adhesion for bacterial counting. And what we could see that they are all indirect measurements with estimated results and therefore cannot truly reflect the actual adhesion status. And this study was providing a new direct measurement approach by using a simple artificial intelligence method to quantify the initial bacterial adhesion on different dental materials using SEM images. So now we are again back to imagery and how some algorithms could, when they are trained properly, save our time and our eyes in taking a closer look. So we had Porphyromonas gingivalis and Fusobacterium nucleatum, which were used for bacterial adhesion on dental zirconia surfaces, and the adhesion was evaluated using SEM images at time points 1, 7, and 24 hours. Image pre-processing and bacterial area measurement were performed using Imkg software with a machine learning plugin. The same AI method was also applied on SEM with Streptococcus mutans, inoculated polymethyl methacrylate nanostructured surface with these time spans up to 168 hours, and then further compare and contrasted with the CLSM method. What we concluded that SEM images can be analyzed directly for both morphology and quantifying bacterial adhesion on different dental material surfaces by the simple AI-enabled method with reduced time, cost, and labor. And here just maybe a couple of pictures. So we see the nano pyramid structured surface, how it was prepared. And here in the middle, you see the bacterial adhesion taking place. So this is how nasty it looks. And the CLSM, live and dead bacteria method. And this is for the control group. Then image adjustment, training bacterial pattern model for the AI to understand what it should spot out on the experimental setup pictures, and then how to carry out the bacterial area measurement. Here are some examples of the area or percentage of Porphyromonas and Fusobacteria occupied area after 1, 7, and 24 hours inoculation. And you may see how it's really, really dramatically growing. Then maybe just to show about something about the mathematical methods, area percentages, so two bacteria in different time points, and linear regression of data. And this is for 1, 7, and 24 hours. And below you can still see as an example summary of the bacterial adhesion results by CLSM, both living and non-living bacteria, and the same images in different cell incubation times. Oops. So you can take a closer look for the details of these two cases I have here. And indeed, what we were concluding was that the AI tool was able to measure the early stages of bacterial adhesion on dental materials with the situations of Fusobacterium nucleatum porphyromonas gingivalis on zirconia up to 1 full day, and then with the case of Streptococcus mutans on nanostructured PMMA for up to 168 hours. PMMA is here because it's still very much the almost only dental denture material. And this is all by direct quantifying the initial bacteria counts, occupied areas from the respective SEM images. And then a new colonized area-time relationship about bacteria zirconia was found, and the same images provided a closely matched with CLSM results of PMMA. This was an exciting experience indeed. Then shall we proceed to clinical assistance and robotics? AI may assist in complex procedures with real-time guidance and robotic precision, decreasing surgery times and human error. Now, we should pay attention that if we say that it would decrease human error, that is certainly possible. But could such algorithms make errors? Of course they could. AI is a predictive tool of unseen data. So it may suggest that this is now a very serious case of oral cancer. And then when you take a closer look and see the patient again, you may realize that that was not the case, but at least AI was drawing my attention that something might be going on. We may quite with confidence say that AI is supporting dental specialties, including endodontics, prosthodontics, caryology, oral pathology, oral surgery, and even I want to mention here forensic odontology. Augmented and virtual reality tools may enhance patient education and dental training. So apparently all this we have been talking already would help very much in education and training. AI-based simulation platforms, they provide today immersive, personalized training environments for you students. Now I don't know how much you are today using AI in your teaching or research. It's one option to consolidate learning anyway. And the AI-based simulations could help analyze large-scale patient data you need to go through, optimize workforce planning, and support evidence-based dentistry. These three things AI-based simulation could help with. We can again make a tiny wee summary here by saying that AI facilitates research innovations and precision dentistry aligned with global oral health strategies. And I'm tempted to say that the two examples I was showing about our recent research were drawing the attention to improved precision and getting a very helpful tool for clinicians. I have here now in one slide, I got several concerns we have. Namely, there are serious risks using AI in dental research and in dental teaching. And if you have online examinations for students, so then there should be very clearly defined that using AI answering instead of your own answers would lead to serious consequences. There must be rules. And the serious risks I would like to draw your attention here is fake data. And even by today, very often if we got a problem in dental teaching or research, the quick answer we might find by Googling. Google it's very practical. I'm sure we all use at least once a day, if not twice a day, to find a quick answer. And nowadays, you may have an option that ChatGPT is making a very quick summary or other bot for the question you are asking. But I'm saying that these answers by AI, the quick answers, should be treated with caution. Google is also finding a lot of data and sources that are just not necessarily even real. Fake imagery is also one of the risks. Fake literature research, unfortunately, if you let ChatGPT make a literature research, it may just provide nonsense. Fake citations. This is an unfortunately true. I'm very much reviewing people's manuscripts from the colleagues in dentistry, and I have come across with fabricated citations. Not very much long time ago. I remember I even found a couple of references that were referring to me and my co-workers. And then I took a second look that was making me think that I can't remember these publications. They sound familiar, but something in the title didn't make sense. Like one of these citations was as if it was from 2010 and referring to femtosecond laser, which was not even available then. And a closer look, I realized that the titles, they sound possible, but the authors were not all certainly included. I could see that very easily. And then the journal was unbeknownst to me. So what I had to do in this case, I was referring somebody's manuscript. So to the journal editor, I had to send a separate message that it looks like there are now fake references in this publication, so please report this immediately to those manuscript authors' university. These are namely extremely serious cases. There is nothing to play with. This must be reported and handled according to the university's internal procedures. And fake publications you may also find with just Googling. So we have so many serious risks just for dental research, and the same risks applies dental educations inevitably. Fake data, fake sources, fake imagery, fake literature research, fake citations, fake references, even fake publications, fake patient cases. Only imagination is unfortunately here the limit. Then what could we see as benefits of AI integration in dentistry? So improved diagnostic accuracy, early and precise detection of dental diseases is supporting timely and effective care. We could also have enhanced efficiency, automation, reducing clinician burnout and administrative burden, giving them more time to focus on complex patient cases, having maybe finally ample time. Could personalized care be closer? Maybe. Tailored treatment plans based on comprehensive data analysis could improve outcomes and patient satisfaction. In preventive dentistry, predictive tools could enable proactive management of oral health and thereby reducing complications. Expanded access. So then the question is, could teledentistry and remote monitoring bring high-quality dental expertise to remote and underserved populations and regions over, let's say, a vast country? Would this be, from the point of view of public dental health, something? Then consistent quality. AI-driven workflows could, in the best scenario, promote consistent data-based decision-making across practitioners and different settings. Then we got something to consider very carefully. Artificial intelligence in the dental healthcare sector is stirring both concerns and hopes. Among the concerns, we could list fear for job threats, challenges in distinguishing between truth and falsehood, and the ability to objectify model interferences, meaning that we still need very much good skills for create algorithms and big data models. There are also risks to personal information integrity and individual freedoms. Um, on the side of hope, despite the current abundance of rhetorical caution, there are potential benefits. So it's like a coin, we got always the flip side. Increases in productivity, enhancement in safety in, say, manufacturing, safety in dental clinic or at hospital, saving time for healthcare providers, less administrative duties. They might be able to uh, redirect to artificial intelligence tools and more direct patient care face to face. A couple of more aspects: data privacy and security. This is something very important, namely handling sensitive patient data. It requires strict adherence to regulations, robust encryption, and controlled access. These are extremely sensitive things, and if these leak out or go to wrong hands, the damage is massive. Also, do we have or could we have algorithmic bias? Because AI models need diverse, representative training data to avoid disparities in diagnosis and treatment across the whole population, across demographics. How about integration complexity? Compatibility with existing dental software and workflows is crucial to adoption and effective use. Regulatory compliance. AI tools used for diagnosis and treatment, they fall under medical dental device regulations that require vigorous validation and oversight. And the problem here may be that are the regulation and legislation following at the same pace of very quick development taking place with AI tools? So are those who are developing the apps, are they faster than the authorities who should pay attention to regulation? Moreover, transparency and trust. I have several times mentioned about the reliability because we are talking about a predictive approach, a predictive tool to give an estimate, an approximation of unseen data. And now here clinicians demand clear insight into AI decision-making process to ensure safety and confidence. We have to feel safe and we have to feel confident what are the outputs of such algorithms. Then we got human element preservation. Empathy, creativity, patient rapport remain irreplaceable. AI doesn't have feelings or empathy. Those only come from you as treatment providers. And AI should augment, it should not substitute clinical judgment and human interaction. These are some very important limits we have at hands. Also, cost and training. Investment in AI technology and staff education is essential, but it can be also barriers, at least for small practices. When it comes to universities, the resources are better, they are guaranteed, and you have trained people ready for further development. When we are talking about, for example, wearables for patients and mobile phone applications. But for small practices, application of AI may be virtually impossible. Something about future, what to anticipate when talking about AI. So AI adoption is accelerating very, very vigorously everywhere, all the time. It's taking place especially among larger practices and dental groups, with independent dentists integrating technologies at a steadier pace. And this is something where we should maintain our critical eye. It has been many times said that if something looks very good, then it can't be actually really true. And critical mind is a key feature for successful dental research, dental education, and patient treatment. Some new AI platforms, they are unifying diagnostics, treatment planning, administration, patient communication into seamless systems when and if things go as planned. Ongoing collaborative efforts among dental professionals, technologists, ethicists, and policymakers, they are critical to address the social, technical, and clinical complexities of AI deployment. So as we can see, we need plenty of communication from not only from universities, but it's also with local authorities, with national authorities. They should provide the guidelines after thorough consultation with us. So now I'm summarizing here what we have today, applications in dentistry of AI. Thinking of restorative dentistry, we got dental caries detection, vertical root fracture detection, apical lesion detection, which are very, very much important in our effort to judge what to do next. In periodontology, I'm here including implant dentistry, by the way. We should follow, keep an eye. Do we find periodontitis or periimplantitis? Diagnosis and classification, and as we know, the etiology for both are very much similar, perhaps surprisingly. In orthodontics, treatment planning and prediction of treatment results may be very much important and helpful in the clinical work. In oral and maxillofacial surgery, tumor, oral pathology, and cancer detection. In prosthodontics, tooth segmentation and classification are in the heart of the discipline. And for example, dental crown design. I'm here mentioning oral pathology one more time. It's part of the OMFS surgery and issues, but now with a wider concept. So this is AI and dentistry very much today. Would it be the same tomorrow? Remains to be seen. Did you know that dentistry is very much suited for AI? So we are luckily working in a discipline of health sciences where AI is almost like tailor-made for us. And why do I say this? If you think about the imagery, screening, treatment planning, and conducting, that's the everyday work. Different imagery materials from the same anatomical region of the same individual, plus non-imagery data, clinical records, systemic conditions and medications, they are available, they are collected. Then the challenge, hopefully with the help of reliable AI systems, would be integration and cross-linking the different imagery materials. Also, many dental conditions like caries, apical lesions, periodontal disease, they are relatively prevalent. There are differences between countries and regions, but this is what is your everyday clinical bread. Building up datasets with a high number of affective cases can be managed. This is important for the training of the algorithm to see what are the affected cases and which are not. However, we can with high confidence to say that there are three main reasons why dentistry still has got challenges. And maybe any one of you would tackle these questions and save dentistry. Namely, medical and dental data are not as available, as accessible as other data. And why are they not available? This is because of data protection concerns and organizational hurdles. These data, are they collected by public or private sector? They are not just accessible whenever we want. Organizations and institutions have their own rules and regulations to follow, and overcome these requires plenty of time and effort. And unfortunately, data is very often locked with segregated, individualized, non-structured, and non-interoperable systems. So this means quite simply that the data may be collected safely in a repository, in a healthcare authorities or organization, but whatever has been the data system to handle. So this is a major system bug for non-communication between different systems. Also, data on each patient, they are very complex, they are multidimensional, they are sensitive, with limited options for triangulating or validating them. You may already be very much aware of this problem. AI algorithms, they can only perform accurately if they are given relevant data to learn from. By using annotations such as bounding boxes or polygons to label objects of interest and highlight relevant areas. And this is something I drew your attention when I was showing our first dental material applications. It's how you create these polygons or squares on the surfaces on imagery. This is part of the training for those who train algorithms must have good understanding and eye on how to label the object of interest in X-ray images. Also, publicly available datasets would be a great resource for AI training, very obviously. Just if you think about Indonesia as a country with plenty of public datasets, you would become very much successful if you get access to the datasets for AI training. However, the trouble for dental artificial intelligence isn't an unwillingness or inability to compile datasets or access those currently available. It's rather the data needed for training artificial intelligence in dentistry. It should be anonymized, and also patient's consent are needed. And this is very important from the point of view of good ethics, ethical guidelines and ethical considerations. Because in dentistry, it's not the dentist's interests, it's about the patient's interest. So we could ask, is a robot going to replace a friendly human dentist who is looking after our oral health? Could this be the case one day? The question also could be, are machine learning and computer vision systems to be applied to support the dentist in giving the best treatment possible? So we are approaching the end of the presentation. What have been now talking about during the 87 previous slides? We have been going through how artificial intelligence is a prediction tool for unseen data. It's nothing else. Artificial intelligence doesn't know a thing. It's you who is knowing many, many things. Artificial intelligence is just a servant for clinicians and researchers. Only and only if it has been trained with an ample amount of clear cases it's aimed at. Now we are taking a look at a few countries, how artificial intelligence in legislation has been defined and treated. So for the first, at the University of Manchester very recently, because of the AI usage rising, university created its guideline on how and when to use it. I'm sure every university today already have created these guidelines. And of course, as a reminder to all of us, be us students, postgraduate students, undergraduate students, so teachers or professors or administrators, we have to comply with these regulations. It's not worth trying to find a shortcut in assignments or some part of the work. It means a no. So University of Manchester, we have issued guidelines which allow students to use AI tools such as ChatGPT to assist in generating ideas and planning assessments, including citing AI-generated content. And this, when and if this is to use, it must be always mentioned that AI was used. However, claiming AI-generated work as one's own is considered plagiarism, and students must follow specific rules outlined by the university. There are concerns risen about tools like GPT-0 and many more detecting AI-generated content in student assignments, prompting the university to address these issues and provide further instruction and code of conduct in relevant cases. These are rules to follow. And in the United Kingdom, there is an AI bill principles which is stating that AI and AI applications should meet the following criteria: safety, security, and robustness. Appropriate transparency and explainability, and fairness. And this transparency it's a very important word, because if we got algorithms we are using in any application in our daily work, how do we know how the algorithm is working? How was it trained? How was it created? Does it leak? Does it transmit sensitive data somewhere else? So we have to know how these algorithms are really working, don't we? And in addition, safety, security, robustness, appropriate transparency, then finally contestability and redress of AI. This is how AI is treated in the United Kingdom. If we, out of curiosity, take a look at the European Union, as you know, we are not anymore part of the European Union. However, it consists of uh, different European countries. They have Artificial Intelligence Act requirements officially. It's important in the European Union countries. They transparency, diversity, non-discrimination, and fairness, societal and environmental well-being, and accountability. Shall we take a look at what the USA is saying today? So they got executive order requirements which are expecting artificial intelligence to be safe and effective protections, data privacy, notice and explanation, human alternatives, consideration and fallback. We are almost at the end of my presentation. Here I got a few references where I have found the material illustration. They are just random pictures of the internet. Has been very inspiring for me to read and understand, and there are already several publications. Biggest risks has been of very much interest. And if you find this review, please take a look. It's giving a nice consolidating background to follow what's going on in the field of dental research, dental education, dental materials, and artificial intelligence. So thank you very, very much. Terima kasih. And next time I think we will see online in September.
Yes, right, Professor. Okay, maybe Professor, thank you very much, Professor Juka, for such an eye-opening and visionary lecture today. It's really fascinating to see how AI is no longer just a concept, but a practical tool that can optimize in dentistry, maybe in clinical and also in administrative issues. And I see how AI help you to find one of our dentists and lecturer. She is in one of your picture in your PowerPoint. That is Dr. Chacha with red hijab in your picture before.
Really?
That is our lecturer and dentist in Malang in University of
That's
Brawijaya.
that's a very
Uh,
interesting coincidence because I was yesterday just with the help of Google.
yeah.
I was using Indonesia dentistry
You
image,
are
and
not mention
that's what I
Malang
found.
or University
So
of
now
Brawijaya or something. Maybe the algorithm help you to find the picture of Dr. Chacha. Okay,
that was very timely.
yeah. And now we have about some minutes for discussion session, Q&A session. I would like to invite all students here or maybe faculty member if here to give a question. This is your chance to interact directly with Professor Juka, maybe about AI or Wednesday topic. Dr. Hanadia said to me that uh, there are no time to Q&A session. Okay.
By the way, now I can see that there are 135 participants. When we started, we had 55. So I have,
Because we have about electrical issue in our city right now,
oh
Professor
dear,
Juka. So I'm
sorry,
sorry for
sorry
that.
for that. But these things, power outage, it happens also here. If it's stormy, you may get power outage. So this is
Yeah.
universal also.
Okay, Suka.
Actually, I think if there are questions, it would be easier if you type on the chat.
Yeah, yeah. Yeah, okay, student, you may also can put your question in the chat box, or maybe if you want to ask directly to Professor Chuka, you can also raise your hand.
Of course.
Yeah, don't be shy.
No, you don't have to be shy with me. But I know
Okay.
today the students are very often, they are very smart and bright, and they may know much more about the AI apps and the usage of AI and chat GPT
Yeah.
than as teachers. So as teachers, we have to try to uh, follow up very closely. But indeed, based on what I have seen and experienced, I would just give a subtle warning that there is no point trying to use AI when it's not allowed to use in your coursework or essays or anything. So please don't try to be smart because the teachers have got tracking programs that can reveal and that might compromise your career.
Yes.
So please make a promise that you follow the university regulations. And when you are professional practitioners, whatever the dental council in Indonesia or in Malang are uh, dictating.
Yeah.
Because not so long time ago, I can't say which university, but I'm related to that university. And there was a case that one student had produced a master thesis, not in dentistry, it was another field, but I can't reveal the details. And it was a scandal. The professor of the student, he should have noticed and checked that the work was not acceptable. He didn't do it, and he also had to resign. It's a very simple thing to keep the atmosphere harmonic and clear and clean and not trying to be too smart,
Yeah. Exactly.
because you are anyway you are the best students in Indonesia when you have selected dentistry, and your teachers are the top teachers because they have opted dentistry out of all disciplines in academia. This is what we believe.
Thank you very much for your words. So, all right, I see some hand raised. Maybe the first question from Igusti Ayu. Can you introduce yourself?
Oh, yeah, sure, doctor. Thank you. Okay, so good evening, Professor Juka.
Morning in Manchester right now.
Yes.
Oh, so sorry. Okay, so good morning, Professor Juka.
Good morning.
So my name is Andila. You can call me Andila. So I'm
Ila.
as a second semester student. So I'm very fascinated by how the AI works in dentistry. So I would like to ask just to clarify and deepen my understanding. So on your slide, the previous slide, you mentioned that AI allows more time for humanized care. So since dental anxiety is a major psychological barrier for patients, do you think AI will ever be able to analyze or predict a patient's emotional fear or anxiety? Or is managing patient anxiety is human clinical instinct that technology can never replicate? That's for my question today. Thank you, Professor.
Thank you very much, Andila. Very
Yes,
good
thank you.
question. So one of the concepts and possibilities with AI might be that uh, with the help of an app, you can spot this anxiety over patient, and everyone is feeling more or less fear. If you go to your When I go to my dentist, I can't say that I'm 100% relaxed. It's something very innate in all of us. But I would say there would be risks in such a tool. So I would turn the question other way around. Having training material, online material to patients who got fear of being to dental treatment. Maybe rather this way, because we could get ethical issues if we start monitoring, how somebody's mind is doing today. There might be just too much to know about the patient in comparison what is necessary at a clinical situation to know. Was this an answer to your question?
Yeah, sure, but how about the humanized care that AI will ever be predict human fear or anxiety the patient have been feeling, or it's just like the dentist, just purely human clinical instinct that technology can never replicate. Like, what do you think about that? Did AI will replicate the emotion or something like in the future?
I believe this is one of the things where where we need rather trained clinical eye of an doctor or other personnel in dentistry. It's something I would be very cautious. I would be doubtful to hand over to any application. But you are raising a very important aspect what comes to public dental health and how to provide care. And was this an answer to your question?
Yeah, it's already answered. Thank you, Professor.
Thank you,
Okay.
Andrea.
Then I can see here online Muhammad Suyafil Ulya has asked, good afternoon, Professor. Thank you for today's presentation. While reading some of your publications, I became interested in your research on zirconia bonding. Yes, this is what I'm very much interested in adhesion. I became interested in your research in zirconia bonding since adhesion to zircon is often considered more challenging than adhesion to other ceramic materials. Yes, that's very true. Could you briefly explain what zirconia bonding is and advantages it offers to clinical dentistry? A very good question. Since we have time and if the moderator allows, I would be happy to explain if Dr. Lalita
Yeah,
is
sure,
happy.
sure, Professor Chuka.
Okay, thank you very much. Yeah, so dear Muhammad, zirconia is a established treatment modality. It's durable, it's aesthetically beautiful, it lasts. However, as a ceramic, one of the drawbacks is that it's a brittle material. So any ceramic doesn't tolerate an impact. Now, um, the current zirconias, they are improved for the strength, but the problem is that we can't etch with the acid zirconia surface. So when you place a lithium disilicate crown, as you know, you first etch it with the uh, hydrofluoric acid, you rinse it, you dry it, you apply the silane, you dry the silanes, then you have the tooth abutment, which you have prepared. You rinse and dry it after etching with orthophosphoric acid, and you are taught to dry it very gently, because if you dry too much, or collagen fibers, as we were talking on Wednesday, they would collapse. Uh, because zirconia is not etchable, the best way is very gently grit blast the surface to get it rough, but not too long. Um, Follow the clinical guidelines. The thinner are the restoration walls, the more critical is grit blasting. If it's too thin, you would initiate initial cracks on the surface very easily. So this is very, as I mentioned on Wednesday, dentistry is very much optimization and engineering. And we need a huge set of applied skills all the time. Uh, we should use apparently gloves, never with naked fingers, to protect ourselves and protect the adhesion, because any fingerprint, innocuous fingerprint, could compromise adhesion. And after grit blasting, indeed, cleaning, cleansing, and then using those recommended cements. this is the major protocol. If you are following each step meticulously as written, you should be successful. But just, I would say that bearing in mind that the adhesion, it just may fail because of many reasons that may be a little bit out of control. It's good to keep an regular control with the patient and check how is the cementation doing. But I'm glad you drew attention how carefully the cementation must be carried out. Please don't ask, as I said, I never give any guidance which products you should select. I leave that for your clinical teachers. If I have my own opinion, I keep it just to myself. But if you have found a good way to cement uh, zirconia ceramics or other ceramics, if you have been successful, you should feel confident to continue doing as you are doing. So, Muhammad, did I answer your question?
Yes, Professor, very clearly. Thank you.
Yeah, excellent explaining.
You're welcome. Thank you for a very, very good
Yeah.
question. And then if I read here, it's Nurul. Good afternoon, Professor. I want to ask about AI-assisted diagnosis. If an AI-assisted diagnosis turns out to be incorrect and causes harm to patient, could this be considered medical malpractice? In such a case, who would bear the legal responsibility? The physician, the AI developer, or the healthcare institution? Thank you, Nurul. I'm very glad you raised such a question, and this is drawing our attention to the risks of AI. Let's remember, AI it's not as smart and clever as you are. It's only a tool. It's a little bit like a handpiece which you are using in your clinic. If you are using a distorted, worn out, or contaminated handpiece, there would be problems. But can we then blame the handpiece? Or who can we blame? Now, AI-assisted diagnosis, it's already here. You may be familiar with already with your curriculum or read elsewhere. I would say that let's be interested in and those diagnosis tools that have been validated. We should feel comfortable to use them. But they are not making the clinical decision. So, as an answer to your question, if something happens, well, unfortunately, I would be tempted to blame them ourselves. And we didn't use our own judgment and clinical eye. Then the fault is ours. Very good. Hopefully, I answered your question.
Okay.
Very good. Then
Professor,
I can
maybe
see.
the last question from
Yes, okay.
our student Anneke Deborah. Anneke Deborah, maybe raise her hand before. Go
Very
ahead.
good. Thank you, Dr. Lalita. So, Anneke, yeah, the forum is yours, please.
Thank you, Professor Juka and Dr. Latin. So actually, my question is kind of similar with Nurul. So I would like a question regarding accountability. So in the event that an AI predicted dental material later fails in long-term clinical use, despite having passed all the computational and in vitro validations, I would like ask the same question, like who do you believe should bear the scientific and ethical responsibility? Is it the algorithm developers or the researchers who validated it or the clinicians who apply it? That's the question. Thank you.
Thank you very much, Anneke, for your very good question. I would also now here draw the attention that we must be confident and aware which AI diagnosis tool we decide to use. So is it something our colleagues are already using, our teachers have recommended, and all of them agree it's a convenient and trustworthy application? Who has prepared the app? Is it someone who's got very good reputation, being innovative and trustworthy things? Again, if you allow me to make this parallel, we need to we need to pick up the right instrument from the tray when we start exploring the dentition of our patient. It's a very cornerstone question you are asking. We have to be aware what we are using. Crown, as Muhammad was asking a moment ago. If we are using the wrong cement or wrong acid for etching, uh, it doesn't lead to a durable outcome. I hope this was an answer. So in brief, so the primary responsibility is in the clinician. But however, if you are using a diagnosis app, and it seems to make the suggestion, you as a clinician agree. So there just might be a case that the app is not working. It's not predicting based on proper training material. So, but can you take the app uh, manufacturer and creator to the court? I'm not so sure. Unfortunately, they may have a very strong legal team who are protecting them. So we always should avoid taking things at that high and difficult trouble level, if you let me use. So we should be confident and happy with the tools, be they mechanical or in silico tools we are using in dentistry.
Thank you, Professor. Excellent explanation. I hope that is truly wonderful to see you again. It has been 2 years since we last had you as a guest speaker here for the same program. We are very grateful that you are willing to collaborate with us again this year. We still have one meeting in September. So
Yes.
see you in September, Professor Chuka. Thank you once again.
Yeah, thank
Maybe
you very
you
much.
have the last statement for the student advice uh, for the student who want to start using AI. Maybe last statement.
Yeah, thank you very much, Dr. Lalita and Dr. Hanadia, for this opportunity. I'm very pleased of the very attentive audience of professors and teachers and students. I can see that you got brilliant students who think critically, and critical thinking is one of the most important things we have. So being critical uh, means also that whatever we hear and read, we should be remain slightly critical, and in some cases check it from other sources. But yeah, thank you for your interest and contributions and support for this session. I have enjoyed very, very much. You got an evening ahead. I still have the whole long day ahead. And please, by the way, let me also, I hope you had very happy Eid celebration.
Amin, amin, amin.
Hopefully you have a good Eid
Yeah, thank you
feast
very much.
with your family and friends.
Have a great day, Professor Juka. See you again in September.
Thank you very much to
Guys,
everyone, and
have a great day.
bye for now, and see you
Bye.
then again.
Yeah, okay, okay.
Thank you so much,
Yeah, bye
Professor.
for now.
Thank you, Professor.
Thank you very much.
Thank you very much.
Thank you.